Welcome to my world, the world of a medical laboratory scientist. Health is wealth, knowledge is power. Today's topic has to do with syphilis. Syphilis is back. Laboratory role. The laboratory plays a major role in syphilis because right now syphilis is just a kind of problem that can easily be treated. But because of the stages involved, the primary stage you may not feel the pain, and then when it heals it goes into the secondary stage, which is when probably the symptoms may come out. But when the symptom is not out, it goes on for years, and then the tertiary stage when it destroys many of the organs. But now we have a situation where syphilis problem is back. Syphilis in itself, you think it's something that should have been eradicated for a long while. But the only thing that can come to the rescue when you cannot see the symptom is the laboratory diagnosis, where you probably want to screen. And one of the opportunity given is when pregnant women are going for their antenatals, they are screened for this VDR, the syphilis infection, whether they are harboring it. So much will be said on this. Syphilis is back. And I'm sure when we go into the slide session, you will get more. Click on the like button, subscribe, and more will come. The outline: objective, introduction, historical timeline, diagnosis strategy, and treatment. These are what I shall be speaking on in this video. The objective: to expose the re-emergence of syphilis and the laboratory diagnosis employed presently to stem the tide. Also, propose possibly newer strategies for its diagnosis. The introduction: syphilis is the name of the disease caused by a spirochete called Treponema pallidum, which is sexually transmitted through the genitalia, which may include the rectum, lips, for gay people especially. It is a thin, delicate, tightly wound bacterium, 6 to 15 micron long and 8 to 14 evenly sized coil that aids its movement, coily movement. They are best seen by an electron microscope or by dark field microscopy in serous fluid collected from a primary chancre or secondary skin lesion. The symptoms are divided into 4 stages if the tertiary stage is subdivided into latent and late-stage syphilis. The earliest is characterized by a painless sore at the site of contact or a rash. Left untreated, however, syphilis can lead to long-term neurological and cardiovascular diseases. The re-emergence of syphilis is not something just happening in the US. There were 7.1 million new cases of syphilis globally in 2020, according to World Health Organization data, which could be ascribed to COVID-19 scourge and co-infection. In 2022, the UK saw syphilis cases reach their highest level since 1948. The rise in cases is something sexual health practitioners working on the front line have grown familiar with, as observed by a nurse on BBC report. When I first started sexual health nursing in 2005, it was quite rare to see primary syphilis, even in a city center clinic, says Judy Crossman, co-chair of the STI Foundation in UK, where syphilis rate jumped 8.4% between 2020 and 2021. Now, most city-based clinics will see at least 2 or 3 patients per day attending for treatment. In January 2024, the CDC and Prevention reported that cases of syphilis had reached their highest level in more than a decade, with more than 203,500 cases of syphilis reported in US in 2022, a figure that is nearly double that in 2018. The cases increased by 17% between 2021 and 2022, surged by 32% between 2020 and 2021 to reach the highest number of reported incidents in 70 years. The epidemic is also showing no sign of slowing down. The Center for Disease Control and Prevention warned, and it has pointed to some alarming new trends during this sudden spike in the disease. The congenital syphilis, which is another way of spread, where a mother passes the infection to her child during pregnancy, often after contracting it from their partners, has risen particularly sharply with 3,755 cases in US in 2022, an increase of 30% compared to 2021, and more than double the number of cases in 2018. The disease can cause stillbirths, infant deaths, and lifelong health problems. Yes, it's historical timeline. Syphilis has been called many names, but just according to the experience, but people more or less joke about it. Even in my country here, it's called Anugbajumo. It was attributed to Christopher Columbus' voyages because prior to his voyage, Europe had no record of disease resembling syphilis. It is divided into two pre-Columbian bones and the post, because the bones are really exposed that before Columbia started his expedition to all the European states to discover the Americans, there's an evidence of the American bones, that is, when they examine to have this sign of syphilis before the ravaging of the Western region. Syphilis ravaged Europe that the war King Charles of France fought in 1494 was regarded as what the defending army was unable to accomplish. Syphilis did. They were devastated because the war campaign was spent in the consortium of female camp followers. Thereby, they were highly infected and they couldn't even fight the war. And so the opposing country could easily overcome them. Since 1947, there has been a dramatic decline explainable to penicillin magic bullet after Savacin was also discovered. The advent of HIV/AIDS saw another upsurge because of co-infection. Syphilis has this co-infection with other STI agents. Here's the laboratory diagnosis strategy. The strategy adopted is based on the symptoms, the clinical presentation, because primary stage chancre, the hard chancre, is so easy to find the serous. But what we experience is that the genitalia is not the only place you find it now. You find it on the lips, on the rectum, as shown in the pictures. Based on where coitus took place, the serous fluid is collected from the sore and examined in a dark field microscope. The appearance is what you see, just like that. The electron microscopy is also shown here, the electron micrograph. You see it, that's it. Non-specific serological tests, Wasserman, VD-Harrell, rapid PR, and the trust are tests that could be done to screen, so that though they are not specific, but when it comes out as positive, because could be a cross reaction with the cardiolipin, then we subject it to more specific serological tests like the TPA, the TPPA, FTA, the various enzyme immunoassays. With these other specific serological tests, then you could easily confirm. But the problem is they don't go away even after treatment. You still find with serological tests showing that is still positive for 6 months or sometimes more than that, depending on the stage of the syphilis. The strategy of testing, which I spoke about, where the pregnant women are usually tested, should not be limited to mothers alone, but extended to their spouses to prevent the spread of asymptomatic carriers, because the women don't appear to have it, because their husbands probably are asymptomatic. Then the gay community is another area where the the various tests could be done to stem the tide. If we really want to stem the tide and probably erase syphilis from the surface of the earth. Finally, treatment. The WHO recommends benzathine penicillin G as the first-line treatment for syphilis, particularly in early and late stages, and also for pregnant women. For early syphilis, a single 2.4 million unit intramuscular injection is recommended, while late syphilis or unknown stage cases require 3 weekly injections. PBG is also the only WHO recommended treatment for pregnant women. It has always also been discovered that some experience of resistance has happened. So, but the way to overcome that is another issue entirely, which may be presented in another topic. Prevention remains safe sex. And as I've always said, if you like my presentations, press the like button, subscribe. You shall be always notified when you subscribe for these videos, and anytime I present in the new one, you will be notified. Watch more of my videos. Thank you.